Today I'm joined by Dr Haitham Hamoda, Consultant Gynecologist and the Clinical Lead for Menopause at King's College Hospital in London. With years of experience in women's health, Dr Hamoda brings invaluable insights into an under-discussed area of reproductive health: premature ovarian insufficiency and early menopause. In this episode, we discuss what POI means, how it differs from natural menopause, the impact it has on fertility, and the latest research on treatments and approaches for managing menopause effectively. So whether you're experiencing symptoms yourself, supporting someone who is, or looking to deepen your understanding, this one is for you. Let's get into it. Haitham, thank you so much for joining me today. Welcome to the podcast.
Thank you for asking me to join you, and I'm very pleased to be doing this.
How have you found your time in Melbourne so far?
Great. Straight to the conference, so I haven't really had much chance to see much of Melbourne. But yeah, I've got a few days after the conference, but the conference has been great so far. So yeah, and what I've seen so far looks good.
Great. So Haitham, what I'd love you to do is tell our listeners and viewers a little bit about who you are and how you have become interested in this space.
I'm Haitham Hamoda. I'm a consultant gynecologist at King's College Hospital. I lead the Menopause Service at King's, and I am a past chair of the Menopause Society.
Amazing. And how do you think that you became so interested in this sphere of medicine?
It was a gradual progression. So I started in obstetrics and gynecology, and then that gradually progressed. So I specialised more into gynecology, and reproductive medicine and surgery is my interest area, which continues to be the case. So my job involves almost a third of what I do is menopause. Almost a third of what I do is infertility and reproductive endocrinology, and another third is general gynecology and surgery. And I find that balance in a way fascinating. It keeps kind of challenging you in different directions, because I do think it's all a spectrum. So you could say fertility is a big part of the reproductive life cycle, and then within fertility you get low ovarian reserve, which gradually can potentially move into premature ovarian insufficiency, and so on. So there is a continuum within that process. Reproductive endocrinology overlaps with it as well. So I like the challenge it brings. Of course, menopause has been, as you're probably aware, in the UK, as it is in Australia, as everywhere in the world, it's good that the conversation is there. Conversation is taking place. People are talking about it, which is fantastic. But there's still a long way to go. There is the issue with awareness, information, misinformation, menopause in the workplace, how access to advice, access to management. There is a lot involved, and of course, you talk about premature ovarian insufficiency. That in itself, it opens a whole different aspect of this discussion. It's not just about, symptoms and what do you do about your symptoms. It's the whole health aspect, What do you do for bone protection? What do you do for cognitive protection, cardiovascular? What do you do about fertility, which often comes into that discussion as well? How do you support people in that situation? This is, for many people, a difficult diagnosis to take at a time where it comes unexpected for many people, and you're trying to put the implications, what can happen, what your choices are, what you can do, and trying to support people within that. So it's all, various challenges that come with it.
So I want to talk about premature ovarian insufficiency. I'd love you to start off by telling us what does that even mean in terms of, definitions, and what does it mean in real life?
So premature ovarian insufficiency is a condition that results from a decline in the pool of oocytes or eggs in the ovaries. And that's really kind of the main issue. And everything that follows on from it is a consequence of that. So to start with, the group that we're referring to with that definition are women under the age of 40. And what is happening is that you get a fall in the number of eggs. And as a result of that fall, the initial step would be the cycles, ovulation becomes less frequent. So the cycles become less frequent. So oligomenorrhea, which is infrequent cycles, would follow on from that. As a result of that infrequent ovulation, estrogen levels become low. So hypoestrogenism results from that, and that will have the effects of the condition, both from a symptom perspective, but also from a general health, bone, cardiovascular, and cognitive. And that's kind of the combination of it. Now, from a clinical diagnosis and a clinical picture, as a result of this combination, you get a reactive increase in push from the brain with the hormone FSH, follicle-stimulating hormone, which is trying to compensate for that lack of ovulation, the fall. So that's really kind of the triad of diagnosis that manifests from it. And of course, when we say fall and decline in the eggs and oocytes, the other aspect that comes into it is fertility. So if fertility is an issue for that individual, clearly their chances of getting pregnant is likely to become less, depending on how frequent their menstrual cycles are.
And so premature ovarian insufficiency, when does it become insufficiency, and then when does it become failure?
We're really kind of moving away from using the term failure because, as you could imagine, you would look at it and think, it's a word that many people wouldn't sit comfortable with.
Well, it's a very catastrophic word.
So really kind of we're moving away, and the term premature ovarian insufficiency is a term used now. It's interesting when you look at the different terms used. So primary ovarian insufficiency still is used quite a lot. Again, not commonly used. So really the terminology that most people would use now is premature ovarian insufficiency. But it's a good question because it's not a categorical thing. You don't go on from normal ovarian reserve to premature ovarian to menopause overnight. It's a process where you get, of course, if you go back to the physiology, if you go back to human nature and the embryology of the ovaries, eggs are produced during fetal life. And once a female is born, there is no further egg production. In fact, you could say the maximum number of eggs is around 20 weeks fetal age of intrauterine age. And you could say there are about 7 million eggs in total in the ovaries. Then by the time of birth, there are about 2 million. And then there is a gradual reduction without forming any new eggs. So you've got almost like a curve, if you want to look at it and say from birth to menopause. And you could say roughly, give or take, about 2 million at the time of birth. That becomes about 400,000 by the time a woman would have her first menstrual cycle, the menarche. And if you look at it then from menarche to menopause, you've got about 400,000 eggs. You have about 400 ovulation cycles on average till the menopause. So it's a gradual drop. So you could say for each 1,000 eggs in the ovaries, one will ovulate, 999 will kind of disappear, become atretic as described, and that's the process. Now, on average, that goes on from early teens to menopause to average age of 51, with a range of 45 to 55. But some women, that could happen earlier. And so you've got, and of course, that number as well is changing. So we're getting studies to suggest that proportion of women going into premature ovarian insufficiency or early menopause is higher than what we thought it was. So we used to quote about 5% early menopause. That's estimated now to be anything between 8 to 10%, depending on which study you look at and which group of women you're including. Premature ovarian insufficiency, we used to think about 1%. Now it's about some studies suggest up to 3 to 4%.
Wow. So
it's probably higher than what we thought it is. Of course, you have a significant proportion that comes from medically induced iatrogenic, as the term is, premature. So if someone has the ovaries taken out surgically or have chemotherapy, radiotherapy, sort of cancer treatment. So that group, of course, can vary, but the number is probably higher than what we thought it was. So that's kind of the description of it. But going back to the point of saying it is a process where you could say you're going to go from normal reserve to a lower reserve, and that drops. And within that, you're going to get manifestations, and it's not going to be overnight. So you could say as it drops, the cycles may get slightly irregular. As that happens, symptoms may manifest. But that is doing it. It's a drop, but within the drop, there are surges up and down with the hormones, so it can manifest in different ways.
And does this group of women experience different symptoms than people who go through sort of the more average perimenopausal transition or menopausal transition?
If you look at the reported prevalence of symptoms, is along the same lines. So if you look at hot flushes and night sweats, they're still the commonest symptom. And again, 50-60% is what's been reported. some studies up to 70-80%, which is these were the figures that you get with natural menopause. So along the same lines, the general symptoms are very similar. Again, you get about 15 to 20% of women who may not experience symptoms. So again, similar to, let's say, natural menopause, where you could say anything up to a quarter of women may not have symptoms. Of course, the discussion in relation to symptoms will be very different because let's say if you're 50 and you say, my periods have become really infrequent, I think I'm heading into the menopause, do I need to do anything? I would say to you, how are you having symptoms and how are they affecting you? And if you say, I'm fine, I'll say to you, you don't need to do anything. And you have a discussion around lifestyle changes, healthy diet, optimizing weight, etc. But when you talk about premature ovarian insufficiency or early menopause, that discussion would have the health aspect as a prominent aspect of it. Clearly, if the symptoms are an issue, you're going to deal with that separately. But you might say, my periods have changed, but I haven't got symptoms that are bothering me. And we'll still say at that age, you still think for bone, cardiovascular, cognitive will take priority. So you could say there is a role for prevention under 45, which is a different discussion that you would have at 50 or beyond.
So can you just explain to our audience, what are these health concerns? Like, what are the health problems that we see women who have their ovaries removed surgically, or whether they have sort of a primary ovarian insufficiency that's sort of natural? What do they experience long-term that we're trying to prevent?
So estrogen is very protective of the bones. Estrogen is very protective of the cardiovascular system and brain function. And if you look at the incidence of heart disease in women, it's lower than in men. And that's a protective effect of estrogen. So if you look at the incidence of coronary heart events in women under the age of 50, it's lower than in men. And after 50, it gradually increases. And by the time a woman is in her 70s and her 80s, the rate is similar to that in men. And that's all the effect of estrogen. So the effect really is an increased risk of cardiovascular disease. And we've got plenty of observational data that show women who go into premature ovarian insufficiency have a higher risk of cardiovascular disease, cardiovascular mortality, osteoporosis-related fractures, and cognitive impairment and dementia. So these are the effects of estrogen deficiency. What we haven't got, what is lacking, is studies demonstrating the effect of estrogen replacement. So it's common practice. If you diagnose now someone with premature ovarian insufficiency, you will say that we would recommend that you take hormonal replacement. And we've got strong observational evidence to that effect that we would say, even though the studies are lacking, it is standard practice that we would do that, and we'd recommend people will take hormonal replacement until the natural age of the menopause of 50, 51 to protect against that.
Okay. And in terms of this group, do you feel that the group who have like a surgical removal of ovaries, given that they haven't had that gradual change and it's more of a sort of a couple of minutes change really in their status, do they seem to have worse symptoms or different symptoms?
So it's, as you described it, you get that abrupt drop and yes, so everything is going to be more prominent in how it manifests. So yes, symptoms are likely to be more prominent because you've got, all of a sudden you kind of got that drop. And a big part of why you experience the symptoms is the effect of the hormone drop on the brain. And you could say if you have this naturally, it's a process that happens slowly. Of course, when it's happening surgically, it's a very prominent drop. So you could say, of course, the studies show there is more of an effect with surgical menopause because you're getting that, in a way, that rapid drop and sharper drop and more significant drop. Because if you were to have premature ovarian insufficiency and you've got your ovaries starting slowly, but you continue potentially to have intermittent ovarian activity, so you're still producing hormones. So yes, it is more of a concern really. When you talk about the risks, that's got to be higher, but you're more likely to have worse symptoms in that situation as well.
Obviously, you were talking about how it would seem that we probably have underdiagnosed people, or it's becoming more prevalent. Which one do you think it is, or do you think it's a bit of both?
I would say it's probably a bit of both. I think it's sometimes people going without diagnosis or having changes in cycle pattern and not seeking help. That could be the case. It could be our ways of trying to pick it up. So I would say probably a bit of both. I do think it's difficult because you've got that medically induced menopause, and that, of course, is a very different number depending on where you are. You could be working in an area where a teaching hospital that deals with cancer or a place that deals with cancer, and maybe the prevalence would be much higher within that cohort. Or you could have a population where that isn't the case, and you might have a different. So these studies, I mean, of course, the figure of 1% that has been quoted really goes back to studies from the 80s. And so when you look at the kind of more recent studies, it suggests that the figure is higher, and it's probably a combination of both.
And in terms of cause, like, do we know, again, I'm not talking about people who've had surgical removal of ovaries, but do we know, is there a genetic element or is there something environmentally that's making this happen?
So whilst there are factors that we know can contribute, genetic being one of them, certain immune conditions could be one of them, and leaving aside, of course, as you said, the medically induced, which could be an aspect, of certain metabolic conditions can be a factor. The vast majority of people we diagnose with premature ovarian insufficiency that's not medically induced are unexplained. So it's a term that people medically describe as idiopathic. And it's basically, at this moment in time, we can't pinpoint it. So if someone was to have natural premature ovarian insufficiency, we do investigations. So you will do chromosomal testing, fragile X mutation. So you look for certain genetic components. You look for potential indications of immune, let's say adrenal immunity or thyroid, not because they cause that, but if you have these, you may also have immunity that may predispose you to have premature ovarian insufficiency. But you could say for the vast majority of people, you don't find a cause and you would say it's unexplained. And of course, the end point is the same. It's a question of counseling about the effects. It's a question of picking up other issues. It's about counseling other members of the family where this becomes also more relevant.
And in terms of, do you ever see people presenting, because I know you work in the fertility space as well, do you ever see people presenting with infertility who then get that surprise diagnosis?
Absolutely. I mean, you could look at that and say, we were talking earlier on about this continuum. It's not an overnight process. So you could say we see people with low ovarian reserve. There are people who have regular cycles and you do ovarian reserve assessment because they're trying to get pregnant and you find that their reserve is low. And that group, of course, at that time, the challenge is what are you going to do? How are you going to compensate for that? How are you going to get the best out of where they are from number of eggs, etc. with IVF? What commonly happens is the conversation then, in many places, is mainly about fertility. And really, that group should have a full discussion about the long-term effects. So it's not uncommon that you see people who present in a premature ovarian insufficiency clinic who would say, oh yes, I had IVF 6-7 years ago, didn't get many eggs, and no one followed it up. And you may see people later on where there might be, of course, osteopenia, osteoporosis and effects. So it's important really at that stage to raise it. And of course, as you could imagine, at that point, fertility is a priority. You've got another aspect that comes into discussion where you've picked up that someone's reserve is low. That's going to cause a lot of anxiety, upset in a way, because you're going to thinking the chance of IVF may become less. So you could see how it could easily, could digress from and not talk about it. And again, especially if you're dealing with a fertility team who may not necessarily have much interest in the menopause and they're dealing with that side of things. But I would say it's important to bring it up at that stage. One thing to mention is when you talk about eggs and the ovaries, you've got a quantity discussion, like a quantity aspect and a quality aspect. So you could say premature ovarian insufficiency is a reflection of low egg quantity. Age is a reflection of quality. So when we talk about fertility, let's say you've got someone who's been diagnosed with premature ovarian insufficiency, and you talk about what are the chances of getting pregnant? Well, you've got two questions that link to this. One of them is what is the age of the individual, because that's your reflection of egg quality. So you could say someone who is with this picture who is 38, 39, or heading into early menopause at 43, 44, are in a different place to someone who might be 10 years younger from an egg quality point of view.
Yes, okay.
But also there's the other aspect of saying, how are they compensating for it? So an individual who you see who might be having a period every 6 to 8 weeks is in a different place and chance of getting pregnant to someone who might say you have a period or two a year. So the frequency of their ovulation, and as you could imagine, if someone's going to ovulate 10 times a year, they're more likely to get pregnant than someone who is going to ovulate 2 or 3 times a year. In fact, there are a good number of studies that show if you have low ovarian reserve, but still having regular cycles, your chances of natural pregnancy are similar to someone who's age-related who hasn't got low egg reserve, which in a way is not surprising, but it kind of, in a way, reinforces that point in saying how you're compensating for it and how often you're ovulating is a significant point as well.
Yeah, absolutely. I actually had a patient who saw another doctor, was told that her AMH level was very low. She was still having regular periods. She completely panicked that she was never going to get pregnant and was pregnant within 6 weeks. So I think, sometimes I feel tests are maybe being taken slightly out of context and people are extrapolating what they mean. Certainly more and more, I don't know what it's like now in the UK. Obviously, I haven't worked there for quite a while, but we can get AMH levels done really easily here. And patients will frequently come in and ask for it to be done because they want to know their fertility status. But I'd love you to give me your thoughts just on the use of that blood test.
I think it's a really useful test. Now, I'll tell you, first of all, what the guidelines say, but then really how you can look at it from a different aspect. I mean, the guidelines are gradually moving to if you look at the earlier guidelines, there was limited evidence on AMH. And of course, the emphasis has been diagnosis with FSH. FSH is basically, you get huge variation potentially from one cycle to another. If you think of what FSH is testing, FSH is simply testing how your brain interacts with the ovary in that cycle. So let's say you have low ovarian reserve. Your pituitary gland in the brain is pushing the ovary. The ovary has got a low number of eggs, but if that month the ovary responds, the FSH that month will be low or normal. But if it doesn't respond, the FSH will be high. So FSH is helpful when it's abnormal because that's not physiological. So if you have an FSH that's 25 or above, you could say that's significantly high and that would suggest low reserve. But a normal FSH doesn't tell us really much because it's not a reflection of what's going on in the ovary. AMH, on the other hand, is you get much less. You get variability, but not much variability. So you're not going to have an AMH of 2 one month and 20 the next month. So if your AMH is on the low side, it's on the low side. Of course, you would always say whatever blood test you're doing, you have to link it with the clinical picture. So an AMH of 2 in someone who's got cycles every month, they're still ovulating every month. An AMH of 2 is someone who's having a period every 3 to 4 months. They're ovulating every 3 to 4 months. So you link it with a clinical picture and a clinical presentation. So I think, of course, so you could say from a guidelines point of view, what the guidelines are now saying is that do it if the FSH is inconclusive. I would say yes, and it has got a role because it's going to give you a bit of an idea. Of course, the interpretation is essential here because if you're going to do an AMH and it's 5 or 6 and you're going to say it's borderline, it's important to have a discussion with the patient to what that means. We haven't got good information to tell us how you're going to move forward. Let's say your AMH is 6 and you could say that is borderline on the lower side. And the next question you're going to ask me, how is that going to progress over the next year, 2 or 3? And we don't know. There have been people who try to do studies where they try and create charts where they would say, right, if your AMH is here, you're probably likely to go into the menopause within this period of time. But we haven't really got good data to say how you will progress. But I do think sometimes in the UK, of course, AMH is not available in primary care. And one of the hesitations that people have is, how are you going to counsel the patient about the results? And I do think that's a valid point because you see many patients who've been told you've got no chance of getting pregnant. And I would always say you can very rarely or should very rarely say something like that to an individual. You may be sat here and saying to me, my last period was a year ago. my AMH is less than 0.2, my FSH is 30, there is nothing to say that you might not be pregnant next month. Yes, your chances are less. The less frequent your periods, the lower your reserve, the less your chances, but the chances are there. And of course, the more frequent the cycles, and if the reserve is the test is slightly higher, which means the egg count is slightly higher, the more the chances. But one can't be categorical. I think one has to be careful, because we do see patients who've been told there's no way you could get pregnant, and you could say, really, you can't really make that assumption. And of course, the younger the individual, the more the chances of intermittent ovulation, and that could happen. And we do see it with people who would say, I've had no period for 8 months, 10 months, and then they're pregnant. So it's important to keep that in mind.
And so just to clarify, if you have primary ovarian insufficiency, but you're having, 1 to 2 periods a year, are you still a candidate to have hormone replacement therapy?
Yes. So if you let's say you present to say you've got infrequent menstrual cycles in that situation, so you would say the concern would be that you're not getting enough estrogen for my health protection, of course, maybe symptoms as well. And in that situation, we would say hormone replacement therapy would be helpful to give you bone protection, cardiovascular protection, cognitive protection. Hormone replacement therapy doesn't suppress ovulation, and as a result, one can get pregnant while taking it. So you could say, so you can take HRT and you can continue to try to get pregnant. Of course, there's also a counter side to that. If you don't want to get pregnant, it's also important to think about contraception, because, again, people will assume because they're in this situation that they're not going to get pregnant. And if you say, well, if you really think, I really don't want to get pregnant, think of using contraception as well. So, yes, so if the cycles become infrequent, we would recommend hormone replacement therapy for general health, plus symptoms if symptoms are there.
For many years in my GP rooms and with friends and family, I heard the same story. People feeling overwhelmed with the huge array of skincare products on the market. Fears around having sensitive skin, choosing the wrong product, or being sold something they don't need. There are so many people intrigued by the latest trends in anti-aging treatments, but unsure if that would be relevant or actually even help them. And many are feeling afraid of being left looking different, silly, or even having an adverse reaction. As a doctor of 25 years, and of course as a woman experiencing the signs of aging myself, I am proud to have created You by Dr Shauna Watts clinics. Led by myself and an experienced team of doctors, our goal is not to change you, just help you become the most confident version of you. Every journey at our clinic begins with a comprehensive assessment by our doctors and includes photography, skin analysis, a thorough exploration of your medical history, and of course, time to chat about your concerns and desires. Together, we create a completely customized plan, helping you achieve the confidence that you've always wanted. We treat all skin concerns, including redness, acne, pigmentation, sun damage, and all signs of aging. We take a holistic approach and only include evidence-based therapies. So if you're ready to start prioritizing you and exploring what we can do to help, please book in for a no-pressure Planning Your Aesthetic Journey appointment. You will leave with a full written plan and information on any recommendations. Our clinics are based at Foresters Beach and Newcastle, and you can book online at youbydrshaunawatts.com.au. So obviously you're very fundamentally involved with the British Menopause Society, and obviously over the last 20 years, HRT got a bit of a bad reputation, which has been hard for it to shake, both among the public but also among doctors. And there definitely remains a lot of doctors out there who are quite scared of hormones. They're worried about taking it, and perhaps maybe still thinking a lot about some of the older studies and data. How do you think we're going to change that and get people to really embrace hormones a bit more as a really valid treatment for women?
Thank you. Yeah, that's a good question. What I would say first of all is the discussion that you have and these data that you're referring to apply to women 50 and above. Very different group, very different discussion. Now, if we start with that group, you would say there is a small increase in risk, and you have to take it in context. So whilst there is an increase in risk, you would say it's looking at the individual. Where are they? What are their symptoms? And yes, there might be a small increase in risk of breast cancer, but there's bone protection, cardiovascular protection. And in that scenario, 50 and above, you would still say for most, the benefits outweigh the risks. But if we go back to our discussion, premature ovarian insufficiency, you would say that wasn't part of those studies. If someone has premature ovarian insufficiency there or early menopause, their risk of breast cancer is lower than someone who is the same age who has got a normal hormonal regular cycles. So you could say, and taking HRT is probably going to take them back to where they would have been had they not been in this situation altogether. So you could say they're unlikely to have a higher risk of breast cancer above their own background risk. So they're almost taking a replacement of what they're not getting. So it's really important to look at it in that context, to say that you're giving it to give them what they're not getting from their ovaries, to give that individual what they're not getting from their ovaries, and to do it till the natural age of the menopause. So the discussion of saying, you know, you do see patients who will say, I've been on it, there might be 40 or 35, and this I've been on HRT for 5 years, and be told I need to come off it. And of course, that shouldn't be the case, because you should be advised to take it till 50. And of course, 50, 51 doesn't mean you have to stop them. Then you have a different discussion to say, we got you to the natural age of the menopause. Now, there are two questions to decide how you move forward. Where are you symptom-wise at this moment in time, and where are you bone density-wise? So the discussion takes a slightly different direction once you get to the natural age of the menopause. But at that earlier stage, really, you could say, if I'm seeing someone who, let's say, 37, 38, you've got an aspect of saying, helping them understand where they are and what's going on, and talking about symptom management, talking about health implications, and talking about fertility.
And in terms of things like cardiovascular risk, if you have someone who, let's say, they have had POI from the age of 35, you know, and you've had them on some hormone replacement therapy, would you be thinking that that person should still be going and having sort of cardiovascular studies around the age of 50 to see where they are in terms of their risk profile for heart disease?
So it's a point to consider. If you look at it in practice, that doesn't happen. So in practice, you don't go and assess to see what you know, but you would say where they are at 35, you want to give them the replacement. Beyond that, you would go and really go with a clinical picture, but we wouldn't do anything differently from that point of view. I mean, I suppose you could say at any age group, people are going to have different cardiovascular risks. You could say, if you say you have a well woman chick at 45, you're going to find some people who've got high cholesterol that didn't know about, some people have high blood pressure that didn't know about. So it's always good to ask the question. And we kind of generally look at it in the same way, although you could say in the ideal world, we've called, you know, for that through the British Menopause Society, is to say, well, woman checks should happen, from a menopause point of view, to understand what you may face and what can be done about it, but looking at other aspects, having a discussion about diet, exercise, weight, blood pressure, general checks, lipid, HbA1c, blood sugar, risk for diabetes potential. So all of these to see where that individual is, where their risks may be from a cardiovascular point of view.
And do we know if we have our POI patient who then goes on to take HRT, does that bring them back to the normal population risk, or do they remain at slightly higher risk of those, bone, cardiovascular, brain?
So that's a good question, because the way I would answer it, and we would answer it, is very much based on plausibility, because we haven't got studies that answer that question. What is the right dose of replacement? What effect would you have? Are you fully reversing it? Are all unknowns. You could look at it and say some people take a standard dose of HRT and they're on that dose. Is that enough? We don't know. What's the optimal dose? Some people say you start with the standard, or some say just above it, or so on. Of course, taking hormones is the starting point and the important point, rather than not taking them. But there are lots of unknowns in relation. What is the optimal dose? Are we fully correcting it? Is there an effect? That's why we do a bone density scan. That's why we continue to monitor bone density. But as you said, with other aspects, maybe we don't follow it. What are the long-term risks from dementia, etc.? We haven't got the studies looking at the effect of the hormonal replacement. In fact, if you look at it and say, what are you giving with the hormonal replacement? You might be giving HRT, or you might be giving a contraceptive pill. And you could say we have got studies that suggest maybe there are some differences between them. Maybe HRT is marginally better than the pill. So there are lots of kind of small points, but I think the main point to say is any hormones you're taking are better than not taking anything. But there isn't a question of saying, dose, optimal dose, and trying to monitor the effect. And I think these are areas that we need more information on with time.
A lot of the conference over the last few days has talked about a lot of things, and every presentation seems to have the caveat of we need more information, we need randomized control trials. And I think, a lot of us feel frustrated because are we actually ever going to get those randomized control trials? Like, I have to say, my gut feeling is no one's ever going to do a big study, anything like the WHI again. We know it was extraordinarily expensive. It was stopped early for various reasons, etc., etc. And so are we going to end up on a pathway where we're constantly waiting for evidence that's never going to show itself?
That is a point that you could say there are certain aspects that are difficult to do. There are certain aspects you can argue are probably not ethical to do. You could say, while we know hormone replacement is good, and if you say, right, should we go and prove it in a study where you give someone with premature ovarian insufficiency, HRT or placebo, I would say that's not ethical. So you could say we're never going to answer that question because I wouldn't want to randomize someone with premature ovarian insufficiency to a placebo. And just on that note, I would say the group that often get lost in this discussion are early menopause. So we talk about menopause and we talk about premature ovarian insufficiency. And I would always say it's really important to talk about early menopause, 40 to 45. So they are a continuum, one would look at it, to premature ovarian insufficiency. And like all things go, you could say the older you get, the nearer you get to 50, the less that risk becomes. The younger you are, the more that risk is. So clearly, say if you're 43, 44, your risk may be different to your risk if you're 25 or 30. But we don't talk about that group in the same way. And you could say, from a point of what we know, we've got huge observational evidence in the same way as we have with POI to say that group are at risk of same thing, osteoporosis, osteoporosis-related fractures, cardiovascular disease, cardiovascular mortality, all-cause mortality, and cognitive impairment and dementia. So that group, I would always say it's important that we don't overlook that because I think guidelines are very good at talking about premature ovarian insufficiency and menopause, and I think it's important to always keep the early menopause group within that discussion. But going back to your point about the studies, there is a study at the moment in the UK, a multi-center national study called POISE, and what that study is looking at is comparing hormone replacement therapy, HRT, versus the contraceptive pill with synthetic estrogen. But of course, what it's not addressing is different doses. Going back to your point about how do we know the optimal effect, but just to see if you're giving someone with premature ovarian insufficiency HRT or you're randomizing them to HRT or to the pill, are one group going to get better symptom control? Are one group going to get better bone improvement in bone density, cardiovascular effects? So that's what that study will answer. So there have been 2 earlier randomized studies, but they were smaller numbers. So this should hopefully give us better information. But yes, I think there are limitations. Some, I think, will get more information with more data. Could be a randomized study, could be registry database. So there's the POI registry, international registry, which is collecting data. So again, I think that'll, once it's available, once it collects enough data, it'll give us useful information. But I think certain aspects may remain unanswered because some of the things would be difficult to do in the sense, like I said, you're not going to be able to randomize someone to placebo versus hormone replacement.
No, because that would be unethical. Yeah, okay, that's really interesting. And so that early menopause group, you feel that they are kind of a bit ignored and sort of under talked about. What would you love to see happen differently around the world for that group of women? I
would personally like to see that group very much included in POI. So rather than saying POI, say POI in early menopause.
Yeah.
And I would say I think guidelines should talk about both groups in the same way. And describing it as a continuum. And I think it's people will understand that if you're going to say that your risk will be less as time goes by, and will be more the younger you are. But it's to include that group rather than to have them separate. Because if you look at many guidelines and you think, right, let me see what it says about early menopause, it's overlooked in many places, or it's mentioned, but not in the same level of detail as POI. So I would like to have that discussion to say that they talked about in a similar line, saying POI and early menopause.
I've got one final question for you, which is around women who have polycystic ovarian syndrome often have irregular periods or very infrequent periods. How do they differ from people who have primary ovarian insufficiency?
So what I would say to that is lack of periods or infrequent periods is a symptom. It's not a diagnosis. So if you come to see me and you say to me, I'm having 3 or 4 periods a year, that doesn't tell me much other than that you're not ovulating regularly. The question then comes, why aren't you ovulating regularly? And if you look at it and you could say, broadly speaking, the 3 categories, of course, in this context, we're talking about premature ovarian insufficiency. They, generally speaking, form a small minority. If you take 100 women, we said at 1%, or let's say 4%. So you could say in that bracket within 100, the big bulk will potentially have polycystic ovarian syndrome, and that is associated with high ovarian reserve, not low. So they're not ovulating. An individual in that situation is not ovulating regularly, but that's relatively easy to overcome with ovulation induction. Another category, which is about 1/5 of people with infrequent ovulation, anovulation, is a condition called hypothalamic amenorrhea. So in that situation, the stimulation from the brain is not resulting in regular ovulation. And that could be either weight loss related, exercise related, stress related, or a bit of everything. And often people in that group think eating disorders and anorexia, and of course that can cause it. Most people we see in that situation haven't got an eating disorder, and they've got a normal low weight. They're not doing ridiculous exercise. They might run 3 or 4 times a week doing 5 to 10K. That's enough to switch off their ovulation, combined with a bit of stress, combined with predisposition. So going back to your question, it's trying to go back to ask, what is the cause of where you are? Which category do you fall into? Now, we were saying premature ovarian insufficiency have low ovarian reserve. Polycystic ovarian syndrome have high ovarian reserve. Hypothalamic amenorrhea could have any. You could say you're almost bypassing the ovary. So it's also relevant in that group to say, as a parallel, let's see what's going on with your reserve. And you might do an AMH and say, oh, your AMH is normal or high, and that's hypothalamic amenorrhea with polycystic ovarian morphology, or it may be low. And that group are not polycystic ovarian syndrome. The ovaries bypassed in this situation.
Yes.
So I say that'll be a relevant question to think about. But just something also linked to that particular point in saying, as it's different, of course, your fertility options are also very different, because when we diagnose premature ovarian insufficiency, the questions that people would ask, well, what can I do from a fertility point of view? It does take out a number of options. If you think about egg freezing, and people often will say, should I go and freeze my eggs? And egg freezing relies on a good number of eggs. And you could say if someone has premature ovarian insufficiency, they're pushing their ovaries to the limit all the time. So really, you're unlikely to achieve much more with trying to push their ovaries and stimulate the ovaries. So you could say egg freezing is not really going to be a realistic option. IVF with their own eggs is unlikely to be a realistic option. Natural conception can be an option if their cycles are relatively regular, assuming there are no other issues. So there's no issue potentially with their partner's sperm or with their fallopian tubes. But you could say natural conception may be the best chance for most people. And of course, if it doesn't work, then egg donation may be something as an option to consider. But if you go back to the group, if you're talking about polycystic ovarian syndrome or hypothalamic amenorrhea, ovulation induction is likely to work, because often the reserve in these situations, certainly with polycystic ovarian syndrome, is going to be normal high. So people can have ovulation induction, or if it doesn't work, IVF. Hypothalamic amenorrhea, the same as well.
Okay, amazing. That's so interesting. I'm going to finish by asking you, what's the one thing that you would like to see change in this landscape that would help women who have premature ovarian insufficiency and also early menopause?
I would say awareness, and awareness going back beyond the starting point. I mean, of course, when you're in that situation, having the information is really much needed. But it's a question of saying, I think everyone should know, be aware of the whole situation. And you could say the whole spectrum. You could say at school, people should know what happens within a reproductive life cycle to an extent that you could know how the end point is, what the menopause is, what happens with it, and that some people can have early menopause and premature ovarian insufficiency and what impact it would have. I think also it's important not just whether someone has premature ovarian insufficiency, is to know the impact of age on fertility. You do see in a fertility clinic, it's not uncommon that sometimes people may not necessarily be that aware of the impact of age on egg quality and the chance of getting pregnant. So I think awareness, accurate information, and really at an earlier stage. But of course, at the time when this is happening, I suppose access to assessment is essential. But once the condition happens, support is key. I mean, you could imagine, you could, if you take someone coming off the pill with a view to either having a break from the pill or with a view to trying to get pregnant, and they don't have a period, and you diagnose that they've got premature ovarian insufficiency, and then here you are talking about bone, cardiovascular, cognitive, fertility. You're throwing so much information, and that individual may even be, let's say if they're single, and they're not going to be in a position to try another variable that comes into it. So support is really essential. And unfortunately, that is an issue because we haven't got much support. You mentioned the Daisy Network. Daisy Network is great. They've got lots of support material. Of course, the British Menopause Society has got lots of material, but support in the way of groups and counselling and all aspects that I think would be really needed. There's a lot to be done there.
Yeah, absolutely. I had a patient who recently went off to a fertility appointment and was thinking that she was going to be going down like an IVF route like her sister had. And, she came after a few appointments, back clutching a prescription for hormone replacement therapy. And that was obviously quite a shock to be thinking you're going off to try and have a baby. And the next thing someone's telling you, actually, you need to have hormone replacement therapy because really you look like you're menopausal, basically.
It is difficult, and I think it's really important to have that all available, really kind of with information and support, definitely.
Amazing. Haitham, thank you so much. You've been completely amazing. You've explained everything really, really well, and I know lots of people are going to benefit from today. When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to. Or if you can leave us a review or a comment, it would mean the absolute world because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.